Good morning, everybody. Josh Burton here again, moving forward with the cardiovascular portion of this review series here. Let's keep going now into acute coronary syndrome. Start off with some definitions here. So stable angina, right? Very common. We see it a ton in the emergency department. 50-year-old male comes in, chest pain, gets better at rest. We typically ask if there's some sort of exertional component to it. I go up a flight of stairs, I get chest pain. I rest, it goes away, or I take nitroglycerin, and it goes away. That's stable angina. Moving on to unstable angina, let's say, same patient, 50-year-old male, has had chest pain in the past, usually goes away with nitroglycerin. But this time, now when I'm just hanging out, I'm still getting chest pain, and it's not going away with my nitroglycerin. That's when we start getting concerned about unstable angina. And then the big one, acute myocardial infarction, myocardial ischemia, Enstemi versus Stemi. This is the please help, I feel like I'm dying, I need some intervention. Going through the question stem, risk factors are always a big component here. So 50-year-old male, history of high blood pressure, diabetes, tobacco abuse, all of these things, has had a STEMI in the past, has a stem placement. All of these risk factors just keep increasing our suspicion for acute coronary syndrome. And this is largely is what has created the heart score, which is kind of the big clinical decision-making tool we use in the emergency department, which can be used again in these questions. So think of your history, right? So it's exertional. It's worse going upstairs, better at rest, or no longer better at rest. EKG has some concerning issues to it. Age is a risk factor. These risk factors become a big deal then when we're working up chest pain in the emergency department. And then as far as our EKG, chest X-ray laboratory analysis, especially that troponin. So clinically, how is this test question going to be framed? Again, 50-year-old gentleman, chest pain. Does it radiate? Yes. Goes to both of my arms, goes to my jaw, my shoulder. They're diaphoretic. The classic teaching in the emergency department is that if the patient is sweating, so should you. So if that ever comes up in a question stem, start thinking of one of the deadly chest pains on the differential, and likely that's what they're talking about. Again, exertion or stress, we've talked about that, and then vomiting. Stemi criteria is very important to know. You'll have that on the test when they show you an EKG, and we want to be able to interpret it appropriately. So the very basic of all, new ST segment elevations in two contiguous leads or two anatomical contiguous leads, more than 1 millimeter of elevation in all leads except for V2 and V3. And in those, if you're a male greater than 40, we're looking for 2 millimeters. If you're less than 40, greater than 2.5. Female greater than 1.5 with no age different. It's probably a little more detailed than what the questions are going to look into, but just so you're aware and know the exception to the rule here, V2 and V3, this is what we're looking at here instead. Progression of the STEMI, you're going to look for QT lengthening. You're going to see the T wave rise and get very large. Then you're going to see the ST segment elevate. Then you're going to see the Q waves form, and then slowly goes back to normal. For some reason, this gets brought up a lot on the test as well, knowing what artery is causing what type of MI, how it presents on the EKG. This slide here, the two big things that I want to hone in on are, I want you to think of the right coronary artery as supplying the AV node and the SA node, left anterior descending artery supplying the bundle branches and the fascicles. And why is that important? Typically, you'll be presented with either like an arrhythmia with that left anterior descending artery causing that, or a bradyarrhythmia. Think of that right coronary. And so if there's some sort of like AV block associated with this, we're cluing into an inferior MI, or the right coronary artery has been affected. And that's how you kind of differentiate those two in how they're going through that question stem. So let's go into the EKGs here. Loads of different ways you can ask test questions on this portion of acute coronary syndrome. We'll make it real easy and brief so we get all these easy points right. Anterior wall MI, it's the left anterior descending artery. Your ST segment elevations are going to be in 1 AVL, and then leads V1, V2, V3, and V4, which is what you're seeing here. And then you're looking for those reciprocal depressions or those reciprocal changes. Anterior, it's going to the opposite side. So in the inferior portion of the EKG, leads 2, 3, and AVF, you're going to see those reciprocal changes. In a lateral wall MI, this is the left circumflex artery. So what we're looking for here is 1, AVL, and V5 and V6. Reciprocal changes, again, will be in the inferior leads 2, 3, and AVF. So again, we have more than 1 millimeter of elevation here, and we have reciprocal changes, and these findings are consistent anatomically with this left circumflex artery. This is a STEMI. Next one is the inferior wall MI. So again, this is the right coronary artery supplying the SA and the AV nodes. Think bradyarrhythmias. Stemi criteria you're going to find in leads 2, 3, and AVF. Again, more than 1 millimeter elevation here. And then your reciprocal changes are going to be the opposite of the lateral, right? So now you're going to see them in the reciprocal changes in leads 1, AVL, V5, V6, cluing you in on, hey, this is Stemi criteria, alert the cath lab. Another common one that comes up, and you might see on test questions, especially with the COMAT, is a posterior wall MI, which typically, on initial appearance, doesn't really have that STEMI criterion. So what we're looking for here is these reciprocal changes of what you see first. So in leads V1, V2, V3, you get these deep ST segment depressions here. And in the right clinical setting, 50-year-old male, chest pain, a history of high blood pressure, diabetes, not getting better with rest, is diaphoretic. This is your EKG. Think posterior wall MI. So this is the circumflex or the posterior descending artery. And what you need to do is look for the STEMI in leads V7, 8, and 9. How you do that is you have to take leads V4, V5, and V6, take those off the chest and move those around to the back in this distribution here. And once you have this presentation, then you'll see those elevations in leads now, V7, 8, and 9. And we'll clue you in on, hey, this is a posterior wall STEMI. Again, activate cath lab. Another common one that comes up that I've seen a few times in different Q banks is what's called the accelerated idioventricular rhythm. So again, you'll see this one. This typically follows thrombolytics. So let's say this is a rural setting, no PCI available, couldn't transfer the patient in time. They get thrombolytics, and then shortly after that, you get this reperfusion arrhythmia that looks similar to VTAC. And instead of freaking out and going into ACLS, this is an okay rhythm. Signs of an improving MI in this situation, according to the American College of Cardiology, is you get this resolution of the ST segment elevations and the presence of reperfusion arrhythmias. And that's what this is. So if you have a question stem that says, hey, this gentleman got thrombolytics for concerns for an MI, following this is now you see this EKG. This is an accelerated idioventricular rhythm or a reperfusion arrhythmia. This is okay, nothing to do. On the test, it'll probably be just identifying what it is and not shocking the patient. All right, going into the evaluation here, so lab markers. Here's kind of a display on how these rise and how long they're available before they go away. Big things here, troponin I is most specific. CKMB, you're looking for reinfarction. Troponin T, a little more specific than the CKMB, but probably the big takeaway here is, what's the most specific test for acute coronary syndrome? Troponin I. What would you use if you're concerned for a reinfarction? CKMB. Treatment. We're going to keep it basic here. So there's other things that I haven't included because they're a little controversial. So we're going to keep on the high topics here. Real easy. IV, EKG, cardiac monitoring, oxygen if they're less than 90%, or if they have respiratory distress. All patients get a high-intensity statin if we're considering acute coronary syndrome. And a common question that will always be asked is, which of the following decreases mortality in acute coronary syndrome? And they'll list like nitroglycerin, aspirin, Plavix, statin, whatever it may be. Aspirin is the right answer. So that's why we give aspirin to everybody that we think with acute coronary syndrome or that has chest pain for that matter. Kind of a curveball to that same question is, hey, if they're allergic to aspirin, what do I give instead? And that would be the clopidogrel. Moving down, so nitroglycerin and platelet receptor inhibitors. Nitroglycerin, remember this decreases preload, decreases oxygen demand. That's the idea on how it's helping in this situation. common question, you'll get an EKG, it's an inferior MI. Which of the following is contraindicated in this situation? Nitroglycerin, right? We don't give something that decreases preload to an inferior wall MI, as the right ventricle is preload dependent. For some reason, everybody likes to throw sildenafil into the mix as well. A similar presentation, 50-year-old male, chest pain, signs of Stemi, takes sildenafil. Which medicine is contraindicated? And again, it's nitroglycerin. So make sure, read through the whole question stem. If that's in there, that's what they're getting at. Platelet receptor inhibitors. Sometimes these will be given in the emergency department, and sometimes they're given by the cardiologist. The big takeaway here, they just need to be given before the time of PCI. These medications are, clopidogrel, ticagrelor, prasugrel. I'm definitely butchering all of those, but, is what it is. But anyway, nitroglycerin, platelet receptor inhibitors are part of that treatment option there. Moving on. There we go. Heparin. Everybody who's got a Stemi, Enstemi, high-risk unstable angina, everyone's getting of heparin. Decrease the incidence of DVT, that's why we're giving it. Decrease the incidence of reinfarction, formation of a left ventricular thrombus, that's the benefit. That's the reason why. Low molecular weight heparin can be given alternatively if someone who is less than 75 years old with no renal dysfunction. That one can be used as well. But big takeaway, anticoagulation, Stemi, Enstemi, or high-risk unstable angina. Big differentiating factor here between Stemi and Enstemi is PCI. So the gold standard is PCI therapy, and that's where most of this needs to go. Where the test questions will play into is, can we get there in time? So first medical contact to PCI, less than 90 minutes, that's what we're shooting for. If the question puts you in like a rural emergency department setting, and you can transfer somebody to a PCI hospital less than 120 minutes, that's what we're looking to do. In order to qualify for PCI, ischemia symptoms less than 12 hours and or ongoing ischemia for 12 to 24 hours after onset will be the patient that we're looking for to do PCI therapy. If for some reason that can't happen and the question stem, says, there's weather, or you can't transfer this patient in time for PCI, or it's gonna be a 4-hour transfer time. At that point, we're getting to thrombolytics. So if it's more than 90 minutes from door to PCI therapy and symptoms are less than 12 hours, we're looking to do thrombolytics. If it's more than 120 minutes from first medical contact to PCI therapy, then we need to be giving thrombolytics within 30 minutes of arrival. 90 to 120 minutes, that's what you want to focus in on these question stems. I have seen this multiple times in different question banks. As far as, what's the appropriate care on this patient. If you can get them to PCI, that's the answer. If you can't and it's taking too long, then it's thrombolytics. Enstemi, can you still qualify for emergent PCI? Yes. So that's where the Scarbosa criteria comes into play. So a left bundle branch block plus Scarbosa criteria technically isn't that full Stemi criteria that we went through in the past few slides. But if there is Scarbosa criteria on there, that would then qualify for PCI therapy, activate cath lab. The other alternative is, the question could say, 50-year-old male, chest pain, at rest, has been given, maximal medical management. We're now on a nitroglycerin drip, continues to have chest pain, unresponsive to medical therapy. What's the next best step in management? And that's PCI therapy. And so that's how you would get to that answer choice in that situation. Big complications that come with acute coronary syndrome. So the major complications with any sort of MI, dysrhythmia, ventricular fibrillation, greatest risk within the first hour of MI. That's what you're looking for in that regard. The other one would be left ventricular failure. Another complication that will typically come up is a left ventricular aneurysm. So this would be, the scenario, more than 2 weeks following an MI. Patient comes in, you have an EKG that's showing this persisting ST segment elevation here, plus these Q waves. you know, they had an LAD infarction. You look at a previous EKG, man, it looks about the same, cluing you in on, left ventricular aneurysm. So this person does not need thrombolytics, but needs to be taken care of appropriately. But that is a left ventricular aneurysm, and that's the EKG on how it'll show up in that question stem. Another complication, something called Dressler Syndrome. So again, time period, somewhere around 2 to 10 weeks post the MI. You get someone with a low-grade fever. They, complain of like a pleuritic chest pain. You get the EKG, and you got ST7 elevations kind of all over the place. And you're thinking, man, this is pericarditis. And the question stem includes, and I just had an MI, a few weeks ago, cluing you in on, hey, this is Dressler syndrome, needs NSAIDs, aspirin, steroids, that sort of deal. So most likely diagnosis, what is it? Looking for Dressler syndrome. All right, guys. That is all. Thank you very much.